My colleague, Doug Owens from Stanford, is going to introduce and moderate the next panel.
Welcome, everyone. I'm delighted to be able to moderate this. So the next panel is going to be Modeling Medicare for All, How Design Options Affect Predictions. And we have two experts in this, Bob Pollin and Gerald Friedman, both from the University of Massachusetts, Amherst. They have great expertise in this area, so we're really looking forward to what you all have to say. So,
great. Well, thank you so much, and thank the audience. I appreciate your willingness to tolerate my New York accent and my New York speaking speed, because I have what really should be 30 minutes, and I'm going to squeeze it into, starting now, into 10. Okay. So how do we pay for improved Medicare for all, and what's the, what are the modeling issues? It's actually pretty simple. And, there's been a lot of back and forth between right-wingers at Mercatus, liberals at the Urban Institute, which Bob will be talking more about. If you looked at Jim's article, he had like 25 different plans that were put out. There are a lot more than that. There's a company, the Lewin Group, that used to do modeling of state single-payer plans. Some of them were in Jim's study. Lewin, you may know, was bought up by United Healthcare. They closed it down. That tells you something about how virtually all people who have modeled improved Medicare for all have found reduced spending, which is kind of interesting because nobody has in any serious way counted some of the costs of the current system, like the extra burial costs for the people who die because of the current system, the lost productivity, or even the pain and suffering. Nobody has modeled the cost to individual householders of filing the goddamn paperwork needed to file your insurance claims. I could go on to the cost of marching down to the bank and depositing the checks if they ever get around to reimbursing you. But anyway, the standard practice is shown here. There are 11 basic variables. That sounds like a lot, but it's really not. Don't worry about it. Everybody, except I gather the Urban Institute, starts out with the CMS projection, Center for Medicare Services, projections for healthcare spending. So you all start out, except for the Urban Institute, start out there. And then you subtract the money that you're going to save. And we get into arguments about the size of all these variables. Insurance administration, that's the money wasted by United Healthcare, et cetera. Provider administration, that is all those people in those buildings where they process bills for the hospitals, or the people in the back of your office as a physician who are talking to the insurance company about, will you allow this, that, whatever. The extra price of monopoly drugs, and again, there are discussions, there's disagreement about how much they mark up drugs in the United States compared to what would be a fair price. And sometimes, people will say, well, I know they mark them up by all this, but you're not going to be able to get that money back. So we can argue about that. Monopoly pricing of medical devices and supplies. Monopoly pricing of hospitals. Now, you want to get somebody mad. I gave a talk a couple years ago. They invited me for some crazy reason. They invited me to address the meeting of the heads of research and teaching hospitals in Coconut Grove, Florida. The rooms at this hotel were $985 a night. So I got up there and I talked about monopoly pricing at Partners hospitals in Massachusetts, the Harvard teaching hospitals. Afterwards, the head of Partners came up to me, really angry. We're not a monopoly. Right. So why do you get away charging 4 to 5 times as much as everybody else. Well, if we're going to price everybody at Medicare prices, some hospitals are going to take a huge hit. And that is a growing issue because, as you know, hospital prices have just been soaring relative to everything else. And then bending the cost curve by controlling inflation. Much of the inflation in healthcare in the United States, inflation rates that are higher than in other countries, 1.5% per year for 40 years, higher than in Canada. And some of that comes from rising administrative burdens, rising monopoly pricing for drugs, and recently, especially, rising monopoly prices at hospitals. So if you control those prices, you're going to be slowing the rate of inflation. And then what I call the magic asterisks, taking after the Reagan Office of Management and Budget, which put in magic asterisks. We're going to save all this money. That's not really fair because a lot of these savings could be real. It's just they're hard to measure. Greater efficiency from a single-payer plan, reduced fraud, maybe greater savings because people will be healthier. And then you have to add, there are going to be expenses. First of all, you're going to be covering everybody in, nobody out. So people who now are getting very little health care because they don't have insurance are going to be getting more. Increased utilization. This is a big variable. Some people put it at 0, other people put it at 20%, because if you don't have copays or deductibles or you reduce those, you're going to be having more utilization of health care. Raising Medicaid prices to Medicare levels. And then another magic asterisk, transition expenses. How much is it going to cost? Here are my estimates. Now, if you looked at Jim's thing, I'm kind of on one extreme. My studies tend to be more optimistic about the savings you'll get. I estimate that 5% of spending over the next 10 years would be saved by reducing administration in insurance companies. That's $2.4 trillion. You can go down and see the rest. Provider administration, it all adds up to close to 30% will be saved, or 34% will be saved. The 10 years bending the cost curve, that starts out little, but it becomes bigger and bigger and bigger, obviously, over time. Extra costs, about 8% by my estimate, because of universal coverage, increased utilization, and raising Medicaid prices. Now, like I said, I'm more optimistic. Bob is a little less optimistic. You go to some of the people further over. But almost everybody, even McCaddis, finds savings net of these greater costs. And these greater costs, they're not really costs. A lot of this is benefits. We've got to start working on the terminology here. Yeah, we're going to be spending more, but you're going to be getting something for it. I go out and I get a cookie. I pay for the cookie. That's not just cost. That's yummy. Yeah. Okay, how are we going to pay for it? I mean, look, there are some good, nice people who think we're just going to print the money. I'm not one of those. If you want to believe that, fine, go ahead, but not me. But you're not going to have to print all that much money. It sounds like a lot, but you're an economist in a big country. We're already going to be spending $28 trillion over 10 years on Medicare, federal Medicaid, tax subsidy of the private health insurance industry. That's like $2.5 trillion over 10 years. And then, a few little things like the VA and the Indian Health Service that we're not going to get rid of. We're just going to keep those as they are. There are other revenue sources that you could think about, but I'm not including them. Like, well, the federal government's going to be spending a lot of money on employee health insurance already. Maybe we should just put that into Medicare-for-All because those people are going to be covered that way. State Medicaid, that's $2.5 trillion. Well, actually, it's more like $3 trillion that states are going to be spending on Medicaid the next 10 years. Well, I'm not sure you can grab that back. Senator Warren thought you could. I'm not sure. They're charitable contributions that are a significant amount of money. Are they all going to go away if we have Medicare for all? I'm not sure. Nobody has counted those in. And then seniors are paying Medicare Part B premiums. I think we should stop that, but, yeah. So you take it all account by my estimates, which are optimistic on savings, but maybe a little pessimistic on actually how much money we already have in the system, and you're going to need $7 trillion over 10 years. You know, come on. That's one Iraq war or something, you know. It's like, not that bad. Okay, I'm just putting some of these things here to give you orders of magnitude or suggest things you might think about. Taxable payroll, $69 trillion over 10 years. So if we just tax payroll, we need 10.5% payroll tax. Tax all adjusted gross income, which would include capital gains, interest, et cetera, profits. Hey, that's only 3%, not that bad. Put a consumption tax on. That's a great one because most people don't realize when they're paying it. A value-added tax, under 4%. Here's the change in net income. Whatever you do, if you do the most regressive form of plausible taxation, middle-income people will benefit. The poor won't because they're already not paying that much for health insurance. They will get better health care. And that's, you know, again, we got to start thinking about the benefits as well as the costs. You know what they say about economists. They know the price of everything and the value of nothing. Middle-income people will be the biggest beneficiaries. Now, in these estimates, like Gabriel earlier, I'm assuming that all the money spent by employers on employee health insurance will become payroll. But that's not really necessarily right. But assuming that, middle-income people, working people, lower working people will get the biggest benefits. But you've got to go all the way out to like 400 grand before anybody will be paying more. And that's with the payroll tax. With the income tax, they do a little, you know, they go even further out. So almost all Americans will save money under Medicare-for-All, not even counting all the benefits. If you don't want to spend all this, there are things you can do. Or if you want to make a better system, you could spend more money. You say, well, we're not going to be able to cut the hospitals that much. That's going to cost you more money. You're going to have a higher payroll tax. Pay physicians more on average. That's going to cost you a little more, a little higher payroll tax. Coverage options. Drop dental. I believe in dental care. I think teeth should be part of the body, and I certainly think glasses are. You know. But if we drop those, okay, you're going to save a little bit of money. You can lower the tax rates a little bit. Cost sharing. I don't believe in cost sharing, but if you do put in cost sharing, of course, you could have lower taxes. What is this? You know, it's a shift from sick people to healthy people. I don't think that's a great idea, but, you know, that's just trying to give you a sense of the types of impacts you'll have. More cost sharing, you could really get the tax rate down. Okay, thank you very much.
Thanks, Jerry. Bob, I just ask that you avoid using economic jargon like yummy.
Thank you very much. Yeah, thanks, Jim, for inviting me. This has been continues to be an extraordinarily beneficial conversation that we're having here, and it's really thrilling to hear so many people out in the audience with so much to say. Just to speak to my own background on this, I'm entirely dependent on the real researchers that have been investigating various aspects of our healthcare system, where our expenses are, how we can bring down costs. I don't have any expertise in that at all. I was recruited into doing research on this by the California Nurses Association a few years ago, an outstanding group, and have been trying to pull together big aggregate stories building on the foundation of the work that a lot of people have done in this room, including our organizer, Jim Kahn, who, as I reminded him, was actually the very first true expert on researching healthcare that I met when I first started working on this. So Jerry, my colleague of 20 years at UMass, gave you a nice overview of the variables. And what I want to do is focus on comparing two studies. If you saw Jim Kahn's slide showing all the different results of the various studies, it's true that if you take the UMass people, it's kind of tilting in one direction, and then you have these other ones that were more, or they were more to the left on the slide, but actually more to the right in the world. So why? Is it just because, you know, we have these, our predispositions are pushing us in that direction? I would argue, and my methodology in working on this stuff was actually always to take pretty conservative assumptions, not to push in terms of assuming that there's going to be cost savings beyond what the literature can bear, and for that matter, in terms of cost increases, like in particular utilization, assuming very high numbers, much higher than people like Himmelstein and Woolhandler would tell us is warranted. Even given that, you saw I end up with a estimate of costs that are dramatically different than what is now, I would say, the most widely cited study in the mainstream, which is the Urban Institute's study that came out a few months ago. So what I'm going to specifically do is compare what I and my co-authors came up with at Perry Political Economy Research Institute versus the Urban Institute. So as you can see, so here's where we are. This is our conclusions. So we have our estimate for the year one of the program of Medicare-for-All. And my estimate is based on the 2017 Sanders bill. And there was a reference that we should really be working on the basis of the Jayapal bill. And I should tell you that I actually am doing some estimates on the Jayapal bill requested by Congresswoman Jayapal, and I just haven't finished. But anyway, I'll make reference as we go along to that. So my estimate with my co-authors was that in year one, we could deliver the 2017 version of a Sanders Medicare-for-All program at $2.93 trillion, which was a savings of about 10% relative to what the government CMS estimate would be under our existing system. We would save 10% and provide good quality care across the board. So we would have better care across the board, and we would be saving 10%. And that is the core of Medicare-for-All. So when we heard Jeff Sachs say, well, you know, we've got to be able to deliver savings in order for this to be politically viable, I'm sure Jeff meant to say we've got to be able to deliver savings and deliver high-quality care. And that is what you can get under Medicare-for-All. If you believe more or less our estimates or my friend Jerry's estimates, that is not the case if you believe Urban Institute. And that's why this comparison is so critical. If you believe Urban Institute's estimate, Medicare-for-All does not achieve savings whatsoever. It increases costs quite significantly. And the fact that this has become kind of the standard reference has very powerful political implications. I'll just mention one. Senator Warren's proposal for Medicare-for-All takes as its baseline the Urban Institute study. And it works off of the Urban Institute study. Now, we can debate as to why Senator Warren's poll numbers have dropped ever since she introduced her Medicare-for-All program. But I would argue that that was not the best methodology for coming up with a cost estimate for Medicare-for-All. It boxed them in on the assumption that the Urban Institute estimates were kind of a good place to start. So our estimate was $2.93 trillion. Urban institutes, and it wasn't based on Sanders, it was more like a generic Medicare for All program, but not all that different in terms of its coverage, was 4.22 trillion. So theirs is basically a 50% jump over ours. And if you remember the old Senator Everett Dirksen's line when he talks about government policy and budgeting, he says, well, a billion here, a billion there, what's the difference? Now we're saying a trillion here, a trillion there. Okay, so we've got a difference of $1.29 trillion in year one. Over a 10-year projection, Perry's estimate was 38 trillion, Urban's 56 trillion. $18 trillion difference. Trillion here, a trillion there. Okay, why? What are the sources of the difference? As it turns out, some of it is pure accounting. So that's actually more than 50% of the one-year estimate. That is, Perry starts with the year 2017 as our baseline, and Urban Institute starts with 2020. And between 2017 and 2020, the base actually goes up by $500 billion. So that's just a matter of pure accounting. Second matter of pure accounting is whether we're including in our budgeting for Medicare for All investment expenditure and public health expenditure. We excluded that because we were focused on health consumption expenditures. So when you account for that difference, that's another $260 billion. So roughly $750 billion is purely results of accounting. Then the other items where these are substantive. The treatment of long-term care. In the 2017 Sanders bill, there actually is no allocation for additional coverage for long-term care. I actually built in $40 billion of extra coverage just as a matter of principle, but the Urban Institute's estimate is $235 billion additional for covering long-term care, so that's a difference of $200 billion. Now here's another critical one, utilization, as I mentioned before. Our estimate was, we built into our study that it would be a 12% increase in utilization. And as Jerry referred to, we actually want utilization to go up, at least the opportunity. That's the whole point, that everyone has access to good quality care without cost sharing. So we would expect there to be some utilization. We can argue as to how much, but I deliberately built in a high-end number. My own estimate, based on our studies, was something like a 9% increase. I made it 12% because I combined my estimate in various population cohorts with Professor Thorpe, Kenneth Thorpe of Emory University. Wherever I had a high-end estimate, I put in my number. Wherever he had a high-end estimate, I put in his number. And that bloated it to 12%. Okay, so 12% is a very high number. Urban, actually, they don't have a number. And I debated the lead author, Linda Blumberg, last month on this. They refused to say what their number is. Weird. But anyway, we backed it out. So according to our methodology of what they should be telling us but didn't, their estimate is 16%. So their 16% number is really extremely high. It's higher than the Mercatus, the study sponsored by the Koch brothers, actually only has an 11.3% utilization increase. So that's $200 billion. Prescription drug cost reduction, we had a 40% cost reduction, which is a lower cost reduction relative to the OECD averages are paying 50 to 60% less for prescription drugs. Why can't we get to 50 to 60%? Well, maybe we can, but we only allowed for 40%. Urban says 23%. Why 23%? They just, they don't want to say 40%. They don't want to say 50%. They don't really give a lot of justification. That's another $100 billion. So here's where we are. The first two items, as I said, are purely administrative. That's $760 billion. The other three, $500 billion, That gets us to this difference of basically a 1.3 trillion difference between our study and theirs for year one. Now, what about over the 10-year horizon? Ours is 38, theirs is 56. The critical issue here, I mean, there's a difference in the base year, but the critical issue here is that we are assuming that once you establish Medicare for all, that we can stabilize healthcare costs as a share of GDP. Also a very conservative assumption, I would add. As Jeff Sachs was saying earlier, we're at 18% of GDP. The OECD average is at about 11% of GDP. If you do everything that's in our study, the US is still at 16% of GDP, 15.8% of GDP. So I'm saying we can stabilize at 15.8% of GDP, which I therefore think is a very conservative assumption, given where other OECD countries are. And the reason I think we can stabilize is because over time we can take into account the potential for gaining efficiencies. That is, reducing the physician-induced demand, reducing the degree of fraud, gaining over time the benefits of preventive care. The Urban Institute says that we are going to keep rising at 0.7% above growth in GDP. So there's standard estimates, which have become the ones that get referred to, New York Times, Paul Krugman, this is the respectable numbers. I think they're extraordinarily high. They're not justified in the literature, but there they are. And on top of that is one little coda. They say in their study, well, we don't actually use the standard data. We use our own accounting data. But if you went to the standard data, the CMS data, we would have to tack on another $500 billion. And like I say, I still haven't figured out what to do with it. The point is that this is an extremely important debate in that what hinges on it is, can we deliver a healthcare system that is able to achieve universal good quality coverage at lower costs? If you believe the Urban Institute, the answer is no. It's no. It's the wrong answer. Thank you.
All right, we've got 7 or 8 minutes for questions. Thank you both very much. If we could get the microphones, and again, please identify yourself, and let's try to keep it questions that are fairly brief so a number of people can get a chance to ask.
My question is, the focus seems to be on cost in the healthcare sector and taxes. You haven't addressed the economic dislocation of all of the people formerly, doing administrative work, et cetera, et cetera. So I'm just curious about how the job implications, unemployment, how all that factors into the overall economic impact.
Thank you very much for the question. There's different perspectives on that, and one of the curious things that's happened from our own study is the thing that's gotten cited the most in especially Fox News, is our estimate that there would be roughly 1.8 million jobs lost through the contraction of the private insurance industry and the administrative reductions, burdens that would result from transitioning. There's no other, when we say there's big cost savings from administration, the biggest way you get cost savings from administration is you don't need nearly as many people doing this work. So that would create dislocations. I think, is that what you were referring to? Yeah, that's real. And, I've been interviewed about this many, many times. They say, wait a minute, Are you one of those guys that's for Medicare for all? And if so, why are you making this point? Well, I'm making the point, number one, because it's true, and number two, because we therefore have to develop a just transition program, and the just transition program has to be central to any Medicare for all proposal. It can't just be a little side issue. Everyone who's for Medicare for all seriously has to also be for just transition. And how exactly you develop the just transition, you know, we have some proposals in our study. They've been criticized as being too generous, as being not generous enough. I think they're not generous enough, personally, but it's something that we really need to work on. And the Jayapal bill does make reference to it in a very general way.
Yeah. If I can add a point to that, and Bob, of course, is one of the experts on this coming out of his work on the Green New Deal. Excuse me. But there's another aspect, which is that if we improve the efficiency of the U.S. healthcare system, we'll be taking a burden off of American business, which will then turn around and increase investment and increase the growth of the U.S. economy and lead to more employment. The money that's saved on people's healthcare expenditure will be plowed back into buying boats and buying vacations and doing useful things, maybe buying solar panels on their homes. And that's all going to create jobs. Plus, when people aren't locked into a job in order to keep their health insurance at a particular place of employment, they'll be able to start new businesses and be more productive citizens. And healthier people will also be more productive citizens. So all of this will create more employment. And I think it's reasonable to say that net employment effect of Medicare for All will be positive.
We have another question. And again, please identify yourself.
Mark Saper. Bob, I know there's an easy answer to this. I'm missing something, but you mentioned stabilizing the cost at 15.8%, but we've been using the current percent of GDP as 17.9%. What do I have wrong here?
I mean, so my estimate, you know, when I said the 2.93 trillion for year one of Medicare for All, that ends up being 15.8% of GDP. So again, I'm working on, what I tried to do was actually be very conservative and not be aggressive in what I think is realistic. So we ended up at 15.8% of GDP, and my methodology wasn't to say, how can I get to 15.8% of GDP? My methodology was to read like the true experts on specific aspects of the healthcare system, such as done by all the, you know, the people in this room. And, you know, and then it ended up at 2.93 trillion, and that ended up being 15.8% of GDP. And then I asked the question, well, how come it's still so high? You know, why can't we get it to 11 like Germany? We could, and if you heard Jeff was one of the readers on our study, and he and I argued a lot about this. He said, why can't you get it to 11? And I said, well, one of the big ways that we could get it to 11 is really to, you know, cut incomes for providers. And I didn't want to take that one on. I'm not sure that's an issue that we want to take on. As he said, his own wife is a physician, but he was very firm. And if you want to, you know, yes, you have to start cutting other areas of expenditure in order to get it much lower than where we are. And so the critical thing, I think, is, okay, we are at 15.8% of GDP. Let's stay there. Let's not, at least over time, not have the cost curve go up. And therefore, let's take advantage of these, you know, these estimates that we, you know, have 30% waste in the system. I didn't take out anything for that 30% waste. The assumption being that over time we could gradually extract percentages of that, and therefore at least stabilize at 15 point. Probably we can do better.
I'm always so much on the extreme on these things that I'm delighted to be able to be more conservative than somebody. So I don't think we'll be able to stabilize as a share of GDP. I think we'll have a slowdown in the rate of growth of cost, but I project rising, slow increases. I use as my slowdown in the rate of growth just the difference between U.S. and Canadian price increases. So, I'm more conservative than Bob about that. It's so nice. I don't get to say that very often.
I think we've got time for one more question.
Hank Abrons from PNHP. Do you include any or forecast any changes in productivity of the U.S. workforce, and what is the scale of that? What would the impact of that be?
I don't think you do either.
I have it in qualitatively, in kind of at the end as a side point. I did not build in that as a significant feature. The productivity gain is obviously in the healthcare system, and that's very, very big. That is by getting rid of this massive administrative waste, and then also getting rid of physician-induced demand and improving preventive care. All of those are healthcare-related productivity gains. Well, I think we will get, as Jerry said, we have a healthier workforce. So people are going to show up at work more so that you don't have as much turnover. But I didn't try to model that.
I do have a graduate student working on it, but he's not that good, so I'm not sure he'll work on it.
No comment. So we have one. You'll get the last.
I have a very
question.
short question. My name is Catherine Donahue. I'm a longtime registered nurse. I have a quick question. Who are the Urban Institute's funders?
I don't know. I know that they're considered, a major, slightly left of center in terms of Washington consensus politics. They're beautifully positioned there. They like staying there. I mean, I was on this debate with Blumberg, the lead author, who was a pretty nice person. She only screamed at me 2 or 3 times. But I would say they represent, I think it's fair to say kind of the Clinton wing of the Democratic Party. That's where they're coming from. We don't like them. Okay.
You can look it up. I did, and I'm not going to say. At one point, I looked up the funders of all the major foundations funding research in healthcare, and it's a little predictable. But you've got to do that yourself. I'm not going to tell you.
I would just add that if you take somebody like Krugman, who is a major force in terms of shaping mainstream liberal opinion. As soon as the Urban Institute study came out, it was like, this is our Bible, this is the one we refer to, this is our reference. And as I said, even the Warren campaign took that as their baseline, which I think was a terrible mistake. Among other things, even if you read the Warren study, in the ways in which they use the they themselves are saying, we don't know where they got their utilization number from. They use it anyway, but what's the it? They don't know what it is because the Urban Institute it's not even transparent. You can't really work with it.
Well, I think we can all agree on the importance of modeling this, and so please join me in thanking Bob and Jerry.
Thank you.